colorectal cancer develops in an adenoma-carcinoma sequence. Colonoscopic polypectomy has been shown to reduce the incidence of colorectal cancer by 70 to 80%. Colonoscopic polypectomy is a relatively safe procedure, yet there is the possibility of serious complications such as perforation, bleeding, and post-polypectomy coagulation syndrome, PPCS. Previous studies on the complications of colonoscopic polypectomy have focused primarily on perforation or bleeding and not specifically on PPCS. PPCS, also known as transmural burn syndrome, refers to the development of abdominal pain, fever, leukocytosis, and peritoneal inflammation in the absence of frank perforation that occurs after colonoscopic polypectomy with electrocoagulation. Recognition of PPCS is important in order to avoid unnecessary exploratory laparotomy, as the syndrome has been shown to resolve with conservative treatment in the majority of patients. However, little is known about the actual clinical characteristics, clinical outcomes, and risk factors associated with PPCS. Although relatively low, the incidence of PPCS has the potential to become a significant public health problem given the large and increasing number of colonoscopic polypectomies performed every year. Cha et al. Analyzed the clinicopathological characteristics, clinical outcomes, and risk factors of PPCS. This is the first study to do so in the English language. They report their findings in their paper entitled Clinical Outcomes and Risk Factors of Post-polypectomy Coagulation Syndrome, a multicenter retrospective case-control study, in the March issue of Endoscopy. Here is what they have to say. Background and study aims. Post-polypectomy coagulation syndrome is a well-known complication of colonoscopic polypectomy. However, no previous studies have reported on the clinical outcomes or risk factors of PPCS. The aim of the current study was to analyze the clinical outcomes and risk factors of PPCS developing after a colonoscopic polypectomy. Patients and methods. This study evaluated consecutive patients who developed PPCS after colonoscopic polypectomies and required hospitalization at 9 university hospitals in the Republic of Korea between June 2006 and June 2011. Data for all patients were analyzed retrospectively. The incidence, clinicopathological characteristics, and clinical outcomes of PPCS were examined. Additionally, patients who developed PPCS were compared with controls who were matched by age and sex in order to assess for possible risk factors. Results. The rate of PPCS that required hospitalization after colonoscopic polypectomy was 0.7 in 1,000 cases. All patients with PPCS were treated medically without the need for surgical interventions. The median durations of therapeutic fasting, hospitalization, and antibiotic use were 3 days, 5.5 days, and 7 days respectively. The rates of major PPCS and mortality were 2.9% and 0% respectively. On multivariate analysis, hypertension, large lesion size, and non-polypoid configuration were found to be independent risk factors related to the development of PPCS. Conclusions. In this study, the rates of major PPCS and mortality were only 2.9% and 0% respectively. Hypertension, large lesion size, and non-polypoid configuration of the lesions were independently associated with PPCS. Therefore, patients may be reassured by the excellent prognosis of PPCS, while endoscopists should be especially careful when performing colonoscopic polypectomies in patients with hypertension or large and non-polypoid lesions.